Hi, I'm Dr. Frank Davis. I'm a podiatrist at the Reno VA, and today I want to talk about the foot exam and how that might fit in with your practice. I'd like to thank you for this great opportunity to increase communication amongst us practitioners, and I think we'll just start with a run through of a quick reminder review of the foot exam, and finally review some common foot problems regarding recognition, management, and maybe consultation. I know this first statement is embarrassingly obvious, but in some cases it just needs to be made. Anyway, moving on to the foot exam, it is very helpful to look at the foot in systems. Of course, vascular and neurological are at the top of the risk list. But this last one here is important too, and it does include musculoskeletal and dermatological evaluation. Of course, the two major pulses are the gold standard of a clinical vascular evaluation of the foot, but I would also like to suggest a capillary filling time. And I usually take this at the plantar tuft of the hallux or the great toe. This gives us a little idea of microcirculation too. Here is a quick anatomical review of the posterior tibial artery around the medial malleolus here. And then of course the dorsalis pedis artery is up here on the dorsum of the foot. Here we have the dorsalis pedis in the left picture. That's, as you can see, found just lateral to the extensor hallucis longus tendon. And the right image shows palpation of the posterior tibial pulse. I usually find that a little more distal than what they're showing there, and it is variable. The monofilament test is a great clinical tool for subjectively testing for peripheral neuropathy. And in fact, it should be performed on all of your patients who have diabetes. The 6 cardinal sites are under the first and fifth met, under the big toe and little toe, on the heel, and on the dorsum of the foot. Do that for each foot. So that was a quick review of vascular and neurological systems, and of course all of these could be done in much greater detail. These are basically the minimums. That brings us to the inspection of the feet, and just start with all the obvious things. I like to call this the 6 faces of a foot. There's the frontal or anterior, there's the posterior view, there's the lateral, medial, dorsal, and plantar views. So that's the 6 faces, but there's really a total of 10 places to look on a foot. Don't forget to look here. Lots of interesting things can be discovered in the 4 interspaces between the toes. This is a quick list of common foot problems. I'm sure many of you have come across these and deal with them all the time in your practices. The left side are some common skin-related problems, and on the right column they're orthopedically oriented type foot problems. This lists commonly seen versus less commonly seen foot pathologies. Again, it probably is not anything new to any of you. Toenails are probably the most common of the most common foot problems that we see. Here are average examples of these named nail problems. These are examples of dystrophic or misshapen toenails. As you can imagine, combining these nails with, say, a diabetic neuropathy is a recipe for disaster. Treatment of fungal nails is frustrating for many patients and sometimes even the practitioner. Some patients can be very obsessive with their toenails. The cure versus control is a good conversation to have with your patients and they need to know that there is a high recurrence rate with even treatment. This is an example of a typical ingrown toenail, and these are some of the common symptoms that are associated with that. Depending on the situation, these can be addressed medically with, say, antibiotics and warm soaks, or surgically with a partial or total nail avulsion or matrixectomy. Moving from nails to calluses, we see here an example of a hard corn, or a holomodurum. Corns are basically just calluses on the toes. This is a soft corn, or haloma molly. Soft corns are typically found between the toes, and hard corns are typically found on the exposed surfaces of the toes, as we saw in the previous slide. These are just examples of diffuse calluses in common areas on the foot. Bunions and hammer toes are orthopedic deformities that often have corns and calluses associated with them. These orthopedic deformities, in conjunction with sensory neuropathy, can cause very severe problems and are worthy of close monitoring by the patient's entire healthcare team. Plantar fasciitis is another common orthopedic problem. In fact, probably one of the most common functional orthopedic problems people seek medical help for, because it is so painfully limiting. It typically manifests as a sharp pain in the heel or the medial arch, and is worse after periods of rest or upon first arising from bed in the morning. As you can see, there are numerous treatments, and these are effective to varying degrees depending on the etiology of the forces. I find that a pair of appropriate prescriptive foot orthotics are very effective at managing this problem. The next of our more common foot problems is the Morton's neuroma. This is an enlargement of the nerve sheaths of the plantar digital nerve, and is usually found between the third and fourth metatarsal heads. I think it's probably more common in women due to styles of shoe gear. Probably the easiest and most effective treatment is wider, better fitting shoes. But the other treatments listed here can be effective, yet more invasive. I would also add to this list the surgical excision of the Morton's neuroma. Now we'll just go through some of the less common foot problems. As you can see here, the first one that comes up is gout. It's not a bad idea to work this up a little further than just treating the acute pain of the condition. Foot infections can manifest and mimic other conditions, but typically has these common traits. Closely related to foot infections is the ascending cellulitis. These cellulitis can often be traced back to infected foot wounds. Also usually traceable back to infected skin wounds on the foot is the aerobic infection. Here in this picture is an example of gas in the soft tissue x-ray, which resulted in a 4-foot amputation on the right picture there. Again, another form of infection that most probably started from a skin wound that became infected. Although the left picture has a 5th metatarsal resection, it appears to have progressed to further bone infection, destroying the 4th metatarsal. These feet are highly susceptible to further amputation. This brings us to the diabetic foot. The diabetic foot is the primary cause of hospitalization from diabetes, and is also the major cause of lower extremity amputation in Western society. The combination of neuropathy, peripheral arterial disease, and reduced immune response all lead to an inability to heal and a high susceptibility to bone infections and amputation. Extreme examples of uncontrolled diabetes can cause a severe loss of protective sensation, and this can lead to Charcot-neuropathy. This is an example of a chronic Charcot foot, and of course you see the associated open diabetic foot wound there. This is an example of an acute Charcot foot. An acute Charcot foot can quickly deteriorate into what I would call a rubble of bones, as you can see in this series that is showing up now. So in closing, I would say do a complete foot exam and decide if you have an emergent or a non-emergent situation. Fortunately, most are non-emergent. Also, I would like everyone to remember that the very first part of a thorough foot exam is to remove the shoes. Thank you.